Welcome to this interview session entitled Removing Aspirin from STEMI Patient. Can we improve bleeding without compromising results? My name is Yoshio Numa from National University of Ireland, Galway and Galway University Hospital. Today we have as interviewees two prominent interventional cardiologists, Dr. Joanna Wipulzikowska from University Medical Center in Groningen, the Netherlands, and Dr. Victor Jimenez from Vigo, Spain. During this session, we will discuss why P2Y12 monotherapy following STEMI can be beneficial for patients and why a healing target drug-eluting stent is potentially beneficial in these patients. We will also learn about the design of a new study named the HT Surpeme ASET, in which Joanna and Victor will be as principal and co-principal investigators. So I would like to start this session with my first question for Joanna. So Joanna, what is the standard antiplatelet therapy after primary PCI in your practice, and what could be improved to optimize antiplatelet strategy for patients with STEMI?
Thanks for having me, Yoshi. So our standard practice in STEMI patients is ESC guidelines, and those tell us to simply give DAPT, aspirin, and one of the potent antiplatelet inhibitors like ticagrelor or prasugrel for a full 12 months. We make some modifications for very elderly patients with high bleeding risk. We sometimes reduce the DAPT then to 6 months, or we de-escalate to aspirin and clopidogrel. But we don't have all the data. I mean, we have quite a few studies now that have looked at reducing aspirin in high bleeding risk patients, but not specifically looking in STEMI patients. We know that the balance between bleeding and thrombotic risks crosses somewhere at 30-day time point. The studies have actually stopped aspirin at 1 month, such as Onyx 1 or a lot of the Science studies. But we know from our own data and our own experience as clinicians, especially also from global leaders, that most of the high bleeding risk events, such as BARC3 and 5 bleedings, actually occur within the first month after your acute coronary syndrome. So a lot of very neat trials, such as MASTER-DAPT, which randomized the patients to monotherapy versus DAPT at 1 month, excluded all these patients at high risk within the first month and sort of avoided this whole problem. And so this is our knowledge gap. We don't know actually what, is it safe to stop aspirin and do monotherapy from day 0.
Thank you, Joanna. So in your opinion, do you think that the further shortening of DAPT less than 1 month or even monotherapy immediately after the primary PCI is a feasible approach?
Sure, I think we don't have the data yet. Most of the studies that have been done to date have focused on the high bleeding risk patients and reduced the DAPT to 1 month or 3 months. We have some studies ongoing. We have preliminary data from the ASET trial, which enrolled 200 patients, but those were patients with low risk coronary artery disease and stable patients. And there were no ischemic events with dropping aspirin at day 0 and doing prasugrel monotherapy. Of course, Pedro Lemos from Brazil is running a large 3,400 patients trial, NEO-Mindset trial, which is enrolling ACS patients and also testing this prasugrel monotherapy strategy from day 0. So we're looking forward anxiously to seeing those results. But specific question about dropping aspirin from day 0 in STEMI patients and primary PCI has not really been asked yet. And so we have this gap in knowledge and we need a trial actually to explore this further. I think it would be probably feasible to do that because especially with prasugrel, which is an active metabolite, we know that aspirin actually in pharmacological studies does not add too much of the inhibition on top of prasugrel. So probably from a pharmacological standpoint, it would be safe and feasible to do that. Of course, we need to confirm this in a large clinical trial.
Thank you, Joanna. So my next question is for Victor. Considering the early cessation of antiplatelet therapy, the early healing after stent is the important factor. So do you think that the stent type matter for the early healing? For example, what did the imaging study show?
This is an important question. We know that the stent straight tissue coverage is important in order to avoid short and mid-term complications, mainly stent thrombosis. With the improvement of stent platforms, several of the latest generation of drug-eluting stents available in the market achieve an important percentage of straight tissue coverage and an early neointimal coverage at 3 months follow-up. In this slide, I showed you the data that includes stents with different straight thicknesses and different polymers, going from permanent polymers to biodegradable polymers to stents without polymers. All of them achieving an early stent neointimal coverage about 75 to 80% of the stent struts. This is data obtained by OCT assessment of the percentage of strut coverage with different stent platforms. As you can observe in this slide, this feature is very comparable with most of the stent analyzed. Also, you can appreciate that the boom stent, which is the previous generation of the HT Surpeme stents, achieved an early stent neointimal coverage about 83% at 1 month, as it was evaluated in the OCT sub-study of the Pioneer 2 trial. And this slide, I show you a case example of this study after 1 month of stent implantation, where you can see the HT Surpeme achieve an 81% of neointimal coverage compared to the 70% of neointimal coverage achieved by science after 1 month of stent implantation. And this data was also shown in the population of patients with high bleeding risk.
Thank you, Victor, for summarizing the OCT imaging study of early coverage after stenting. So what would be the advantage of HT Surpeme stent for a short or reduced antiplatelet strategy?
So the HT Surpeme, that HT states for healing targeting, is a drug-eluting stent. It has a bioreabsorbable polymer made of a cobalt chromium scaffold and with an open cell design and helical link connections. This feature allows it to be used in a wide variety of clinical scenarios and also facilitate the early re-endothelialization and inhibit excessive neointimal hyperplasia. The HT Surpeme stent has very unique features that make it safe for its use on situations in different clinical scenarios, also different populations, and even in patients needing short dab duration. The stent has a very unique and shorter drug release compared with other stents, achieving more than 90% of drug release into the vessel wall in 28 days. Also, the dose of the drug in the stent, which is sirolimus, is the minimum amount of drug needed to exert a potent antiproliferative effect after stent implantation. Another important aspect is its polymer, which is a biodegradable PLGA polymer, which is reabsorbed into the 2 months period, a shorter time compared with other bioreabsorbable polymers, and of course different when it's compared with a permanent polymer. And as we saw previously, strut coverage is really important, but I would say that the quality of the tissue that covers the stent struts is very important. As you can see in this study evaluating the permeability of the endothelium with 3 different stent platforms, you can nicely appreciate that the endothelial impermeability remains very well preserved with the HT Surpeme stent and is very compatible with the bare metal stent, as well as the endothelial barrier function assessed at 90 days by B gathering and confocal microscopy. So all these features make this stent very favorable to be tested in an ASET trial, an exciting upcoming study.
Thank you, Victor, for actually to introduce the last topic of this interview session. So, Joanna, what is the design of HT Surpeme ASET study, and could you elaborate what the objective of this study is?
Sure. So we'll try to begin to fill in this knowledge gap that we have. And so HT Surpeme ASET trial is actually embedded within the Pioneer 4 trial. And it will isolate the patients presenting with STEMI who only have one single culprit lesion and no other residual stenosis in other vessels. And it will actually, after they had gotten their medications in the ambulance, let patients skip aspirin completely from day 0 or day 1 post-procedure after a successful PCI. It's not mandatory to do an OCT, but it's at the discretion of the operator to confirm that the stent result with the Puma HT Surpeme is perfect. The primary endpoint of the trial is going to be composites of cardiac death, TVMI, definite ST, and also BARC3 and 5 bleeding in 1 year.
Thank you, Joanna. So I think it is a very unique study to test this monotherapy from the just after the primary PCI in a setting of the STEMI. Actually, this is the first study to focus on this population, and the usage of the HT Surpeme will give you some comfort to use it in this indication, because this stent facilitates early healing, as demonstrated by Victor in some OCT studies. So I think we really look forward to the start of this Surpeme HT ASET trial. And I would like to thank Joanna and Victor for their clear explanation and discussion on this topic of antiplatelet therapy following STEMI. Thank you for watching this interview session, and we wish all the fruitful and successful meeting in Paris for EuroPCR 2022.